Okay, good evening and welcome. Today, we have our first budget meeting, today being April 4th, 2024. We're going to call this meeting to order. Madam Secretary, could you call roll?
Yes, sir. Ms. Luna Chavez?
Present.
Mr. Overfelt?
Present.
Ms. Gonzalez?
Here.
Mr. Mesa?
Here.
Mr. Galindo?
Present.
Ms. Amy Haynes? And myself, sir, we have a quorum.
Thank you very much. Let the record show that we do have a quorum of board members and that this meeting was duly called in accordance with the Texas Open Meetings Act, Texas Government Code, Chapter 551. We're going to dispense with opening ceremonies, if that's okay. We just have our budget meeting, so we're going to go right into our budget. And we'll turn it over to, who will be the first person?
Mr. Chapa.
Mr. Chapa.
Good evening, President Mesa, Dr. Rios, members of the board. I'm here to present the sustainability plan for the operations department today. The first slide is the project dashboard, but I'll skip that and come back at the tail end. We'll start with the HVAC component of it. Currently, for this upcoming school year, we're proposing a total budget for HVAC of $205,000, which includes $100,000 for Garfield Elementary, $30,000 for the annexes 1, 2, 3, and 4, as well as $75,000 earmarked for SPC. The next is fencing. We're proposing $189,240 for San Felipe Memorial Middle School, $143,070 for Blended Academy, and $309,150 for Buena Vista Elementary, for a total of $641,460. Athletics, we're proposing a budget of $810,000 to replace the lighting system and upgrade it to LED at the Rams Stadium. The next tab is campus furniture, grossing $60,000 for campus furniture for San Felipe Memorial Middle School. The next item, asphalt. We're proposing $100,000 for the warehouse parking area and as you approach the building. The next two tabs are for painting. The first one is interior painting. We're proposing $120,000 for Garfield Elementary and $90,000 for Lamar Elementary, for a total of $210,000. As for the exterior, we're proposing $60,000 for Buena Vista Elementary and $55,000 for Lamar Elementary, for a total of $115,000. Technology refresh, we're proposing $15,000 for HVAC equipment for the MDF, IDF closets throughout the district. Also, $60,000 for used department service trucks, as well as $60,000 for the E-rate funding, the 20% contribution that is required of the district. Service vehicles, for maintenance department, we're proposing $200,000. Food service equipment, there's no funds proposed for this department. And the last, roof repairs. We're proposing $375,000 to address the issues at the Del Rio High School, the 800 wing, 900 wing, 1,000, 1,100, and 1,300 wings. and projects pending assignment, we have $80,000 proposed for a retention pond slash Old Garfield roadway that would help alleviate flooding issues at Blended Academy. So we're back to the starting point in the project dashboard. When you tally all these numbers, the proposed future allocation is $2,931,460 for the operations department.
Yes, Dr. Rios.
All the projects that are listed for operations, these are requests that are often deferred. Towards the end of the meeting, when this Childress goes over the budget, you'll see that there are only a couple of these items that we're bringing forward, and then we have to consider either continuing to defer some of these projects or look for alternate funding, but that'll happen at the conclusion of the budget cycle process. This is just what administration is requesting as part of this year's budget, but we certainly will not be able to come anywhere near the 2.9 million. However, these are projects that are pending. For example, on the fencing, through the grant that we're going to be receiving, we're going to do the most, or fill the most emergent needs. And we know that the grant's going to cover that. But the fencing, for example, that's posted here, we will not be able to do that with this budget cycle. So just know that this is a need list, but it's not going to make its way to the general fund budget.
Okay, questions from board members?
Yes, sir.
Mr. Orfeld?
So I'm just gonna go through some of the pages, sir. For HVAC, the Student Performance Center, 75,000. Is that to replace the existing hardware that's up in the, I guess, the units, and everything, and then what's the current age on everything? Because we opened this in when, 2017? 2016 is when we opened this building, so I'm just curious as to age.
On to 8 years. It's
8
as
years.
old as a building is,
Uh-huh.
8 years.
So that 75, is that for new compressors and?
But the plan is, we are experiencing issues with 2 VRF units, and those are specialized units because of the low plenum between the 2 floors.
Mhm.
So last year, we replaced some equipment or some parts to one of them, and it only lasted about a year. It was minimal investment. When I say minimal, it was approximately $3,000. So we took that step. But we continue experiencing situations, so we're looking at proposing that, we see the writing on the wall, and it'd probably be better to replace the unit. And since it's approximately 50 to 70% of its life usage, it'd probably be a lot better to replace.
Okay. For lighting at the stadium, I know you said we want to go to LED. Did we just recently go through replace a bunch of lighting in there at the stadium?
Yes, sir, last summer,
Uh-huh.
prior to the football season, we replaced some burned-out bulbs with similar bulbs,
Mhm.
but we spent approximately $30,000 on that project. But the need or the wish is to replace to LED to reduce electrical consumption as well as provide a longer lifespan.
Okay. Asphalt at the warehouse. You said the drive up and then the parking lot back in there. Is that just because 18-wheelers and bigger delivery trucks have just been tearing the
Correct.
stuff up?
It's been deteriorated over the years because of the delivery vehicles and just the traffic movement. Turning movements are worse on asphalt than straight line movements. So as the vehicles turn and back up and so forth, it just deteriorated the asphalt there.
And I'm sure it's more expensive, but have we thought about over time going in and possibly just converting all of that to one big concrete slab?
It
So as
would
not
definitely
to-
have to be in stages. And the other problem is we would definitely need to stage it to provide service to the facility. So that would be an excellent solution. Obviously, more expensive, as you stated, and more time consuming, but it would have to be done in stages.
Okay. And there was, let me find it, I skipped it. There was something about used vehicles,
That was in technology.
technology.
Service, used department service trucks.
Yeah, so used department service trucks, does that mean seeking out pre-owned
Yes,
vehicle or
sir.
replacing?
Basically, seeking out what Mr. Salinas stated earlier, that he was looking at the mid-size vehicles. He did some research, like basically what he alluded was like the Chevrolet Canyon, the smaller vehicles, just to get the department personnel from point A to point B.
Alrighty, thank you, sir.
Yes, sir.
Anyone else? I have a couple of questions, Mr. Chapa.
Yes, sir.
On the roof repairs, did we get insurance reimbursement for these hail damage?
I believe so. I'm not too sure about it, because those are tar and gravel roofs. So I don't know what kind of level of impact and which actual roofs were covered under the insurance.
Dr. Rios?
We got partial reimbursement, Mr. Mesa. The last hailstorm we got, it was terribly underfunded on the reimbursement that we got. This money is not to make those type of improvements from the hail damage. It's just to improve overall wear and tear on it.
So would it be possible to get a report later on as to, I know that we hired some legal assistance in regard to the reimbursement.
Yes, sir.
Can we get a report on that later on?
Sure,
And-
absolutely.
And I know that this will be an interactive worksheet, so my other question to you is, have you met, Dr. Rios, with the principals yet to see what other items they will be needing in their facilities?
No, sir, we have not. What we are currently doing is we're using our internal department to audit all of the restrooms on the campuses to see what damages exist and see what we can fix. And then here after the next meeting, we'll ask if there's any projects that are outstanding or that they would request, but we have not done that yet, primarily because we would seek to do that with the budget from the department and not ask the board for capital projects for the campuses other than what we've already outlined.
Okay. Just want to mention something else for the board members is that at some point, we're going to have to, again, put our thoughts in regard to an interactive worksheet. I know that some things that we have here, they don't seem urgent, when we have some other higher priority. So we will need your valuable input in regard to every item that is listed here. So either, again, be asking the questions or be thinking about areas that we might be able to make some cuts. Okay. Any other questions? If not, thank you, sir.
Thank you.
Okay, next we have a health insurance update, Sandra Hernandez.
Good evening, President Mesa, Dr. Rios, and distinguished board members. This evening, before our health insurance update, we have invited Brown & Brown Insurance, Mr. Greg Coldaway and Lexi Young will be here to do this evening's presentation. At your desk, you have a copy of the presentation. You actually have a duplicate copy also in your binder as well. And I'll turn it over to Mr. Coldaway.
All right, good evening, everyone. Good to see you again. So this is obviously a board workshop to contemplate funding for next year, and part of that is to see where we've been so far. So if I can figure out how to advance this. So I think you've seen this graph before, but we continually update it, and as you know, we track the cost of your health plan on a per employee per month basis, and so that evens out things over time and numbers of people enrolled. So in 2021, the end of 21 was our last year with Aetna, so that's the high point, and that upward trajectory was the kind of the catalyst to suggest doing something different, which we've now done over the last 2.5 years with a different type of plan, as we've discussed many times. And that cost has gone down, and a little bit of an increase in 23, but back down again in 24. So all of that is great, and we're very pleased with that. So here's the actual numbers, and I break it down into really 3 components to get a total. It's the medical cost, what we spend on doctors, hospitals, what we spend on pharmacy, and what we spend on administration, stop-loss insurance, all the things that go towards administering the plan, and then a total per employee per month cost for the year. So 24 year to date, we're really only talking about January, February. We don't have March data at this point, so that's all we're talking about. And if you look down the pharmacy line to 2024, you'll notice that it's a substantial increase over prior couple of years, and that is primarily because those pharmacy rebates, which we get back from manufacturers, we've not received a payment yet in 24. We should in the next 30 to 60 days, and then that offsets some of that. That'll reduce that number back down to more like what we've seen in the last couple of years. So I just didn't want you to think we suddenly had a huge jump in pharmacy cost, because we haven't, because these other numbers are offset by rebates that we've actually received during the years. So year to date, we're down about 10% over last year, so we're pleased about that. So generally speaking, I'm very optimistic about future cost. I believe in the plan we're doing. I do believe we are paying the lowest unit cost, meaning the lowest price that we can actually purchase health care for. But I do want to suggest that I'm not as optimistic about 2024 for a couple of reasons. So overall, every study I'm reading these days suggests that healthcare and premiums and costs will increase about 8.5% in 2024. And there's a couple of reasons for that. A huge reason, 1% of that 8.5% is made up of 2 or 3 drugs. All the GLP-1 drugs, the Ozempic, Wegovy, all those drugs that are being used to treat diabetes and weight loss. And I'm sure you've heard about it on the news, but this is just a graphic to help you see the growth of spend in those drugs. This is just one of those drugs, and you can see the increase in, this is their sales of this drug, from Q1 of 22 to Q2 of 23. It's like a five-fold increase in the spend on those particular drugs. Well, your group is experiencing that same level of increased spend on these drugs. And the reason is they are effective. They are helping diabetics, and they're being widely prescribed for that reason. So I do think we're going to see increase. I don't think it's going to be 8.5%, but this is just my educated guess, I would say. So there's two, as I said, there's two things I think that are impacting costs going forward. One is the use of those kind of drugs. That is going to drive higher pharmacy spend, and no question. The second thing is we're aware of a number of severe cases that are happening in 2024. We know of 12 individuals who are on transplant lists for this year. Not all of those will happen, but some of them will happen. Those are obviously very costly procedures, somewhere between $100,000 and $200,000 each. 100 on the low end, 250 on kind of on the upper end. So that plus the drug spend is leading me to project that, I think it'll be somewhere around 6% overall cost increase in '24. And the only reason it's not more is because we are in fact paying lowest unit costs. So for example, our contract at Val Verde Regional Medical Center, which is our largest provider by far, that's not going to increase. I mean, the utilization may increase, the number of visits may increase, but the prices are not really increasing because that contract is based on a percentage of Medicare, and Medicare pricing hasn't really gone up. We have a whole bunch of folks who need surgeries and things who are using our bundle price or bundle procedure methodology. Those aren't really going up. So our unit costs are not really going up, but it's the severity of some of the members' claims that I do think will impact cost going forward. So I've modeled that, and this I know this is a very, very busy spreadsheet, but I simply took what I know for January, February, took last year's costs and increased everything by about 6%. And when I do that, I get to a per employee per month cost of about $918. So at your current funding levels, that leaves a deficit that has to be made up out of other sources of about $2.5 million. So I know that's been doable over the last few years. I know budget circumstances have changed. So anyway, that's kind of what I expect. Obviously, it could be much better. If we continue on the trajectory of January, February, it'll be better. But I don't think we can hang our hat on that. I think we have to put some reasonable expectations about what's going to happen and not just be overly optimistic about what these costs are going to look like. So what are the alternatives to this? Here's what I don't think is an alternative. I don't think a Blue Cross or Aetna or Cigna or somebody like that is going to offer anything of value because we're already paying prices far less for care than what they're paying. So same utilization, higher unit cost, you get much bigger cost. So the only solution, and it's unique to Texas public schools, is TRS Active Care. And so TRS Active Care, as you know, is a pool run by the state for districts all over the state. And the rates are set by region, and so you're Region 20, I believe, so Region 20 has a specific set of rates for these programs. The primary reason that these rates are what they are is because the state has subsidized this pool to the tune of about $1 billion a year over the last few years. So the rates that TRS charges don't accurately reflect their cost because they have this influx from the state, and so far they've been doing it. Now, the state's not obligated to do that. They may not do it in the future, but for the last several years, they have in fact been doing that. So if you look at kind of the plans that they offer, I want to give you some brief description of what those are. So if you opted to do that and say, okay, we're going to abandon our self-funded plan, we're going to enroll in the TRS Active Care arrangement, a couple of things about that. Number one, the earliest you could do it would be September 1 of 2025. So we do have a good bit of time before you would be actually able to make that transition. So we still have to deal with what we have to deal with over the next 12 to 18 months. So, but to look at the plans themselves, they're administered by Blue Cross Blue Shield, so essentially members are on a Blue Cross plan. The plan that most people are on is the first column there. It's called Active Care Primary. And a couple of things about this plan. Number one, it is in-network only, so there's no out-of-network coverage, which not terrible given Blue Cross's network incorporates most providers. The second really thing about it is that it's a primary care driven plan, meaning that every member must select a primary care doctor from their list, and then you do not have the option as a member or patient just to go see specialists. You must get referrals from that primary care doctor. So the effect of that is a lot of some hassles for the members, more things for them to do. So you don't just say, I hurt my knee, I'm going to call up an orthopedic guy. You can't do that. You have to go make an appointment with your primary care doctor, get a referral, and then that's how that works. It's a $2,500 deductible, then the plan pays 30% or 70% after that, up to a $7,500 out of pocket. You have some copays for your office visits, but most things, the deductible applies, with the exception of your office visits, basically, and your pharmacy. The effect of this on your members would be much, much higher out-of-pocket cost when they're seeking health care. No, there's no question about that. I've shared some reports with you previously about what your members are actually spending out of pocket on the plan you have, and it's virtually nothing. I mean, they have very, very little cost. That would not be true with these TRS plans because most of what they're going to do, other than office visits, is going to apply to the deductible. There are no options. What you see in yellow is what we call enhanced benefits. All of these things under your current arrangement are covered at 100% with no cost share by them. So it's anything at Val Verde Regional Medical Center, the doctors that they own and employ, our surgical procedures, our imaging, all these things that they can get done now at no cost are all going to apply to the deductible under a TRS Active Care plan. The other plans, the third one is similar to it, just a little bit lower deductible. The middle plan is a high deductible qualified plans, so it's, I believe, a $3,000 deductible, and then, so nothing gets paid until you've met that deductible under that arrangement. But, having said all that, you know, I don't think these plans deliver the value to your members and your employees, but when you look down at the price point, they're extraordinarily less expensive to buy. And again, the primary reason for that is the state's throwing a big pile of money into that pot every single year to subsidize these plans. So that is an option, and it's not, it may be the only reasonable financial option, I don't know, but that is the option that would make the most sense if you wanted, if budget circumstances required a change. Because of those out-of-pocket costs, I just wanted to show you another way you could attack that. So this is what some clients do. Say, okay, we have these TRS plans, or could be any commercial plan, but we think the out-of-pocket cost is too high. We can insure that through a separate carrier that reimburses them up to $2,500 of that deductible or out-of-pocket cost. And so what I've done with this is simply incorporate the cost of that plan into the premium numbers you see below, and it's still, even doing that, substantially less than what you're budgeting now. So that's just another way, an option. I wanted to give you a couple of ideas about how you might attack this. So this is what that GAP plan actually looks like. It essentially reimburses any deductible or co-insurance amount up to $2,500 per person or $5,000 per family. It does not reimburse copays or pharmacy copays. So it's really anything that applies to that deductible. So just to give you a sense of what this looks like financially and why it might be the right thing to do. So currently we have about 1,367 folks enrolled. Your current contribution is $640.01. And so your annual contribution is about $10.5 million. We know that's not all, however, because you brought money in from your fund balance or other sources in addition to this $10.5 million over the last year or two. So, but this is just the actual budgeted contribution by the district. So if you set your contribution at 100% of that lowest active care plan, that's at 376. So that 10.5 goes to 6.1. If you added the GAP plan to it, then you're at about 7.3. So still, $3 to $4 million less than what you're currently spending. So would this be a good idea from a member standpoint in terms of how they're accessing health care and the health care that's being delivered to them? Absolutely not. But budgets are what they are, and we understand that. And so I just wanted to make sure you were aware of all the potential things that it could happen if that's the deal. So that's my report for this evening. Certainly open to any questions you may have.
Yes, sir.
Mr. Orfeld.
Okay. I wrote down lots of notes here, particularly on the TRS active care presentation versus the one that we currently have there. One of the remarks that you made was through Blue Cross Blue Shield, have to have the PCP, and you say, and it says no out-of-network coverage, but you alluded to the fact that Blue Cross Blue Shield is pretty much everywhere.
Correct.
There, so, whereas the current one that we're under, Kempton, is very, very selective. In particular, the providers are extremely selective of going in and taking that. One thing it says here about out-of-network, and I want you to clarify for me, out-of-network coinsurance. It says the Kempton plan, all providers are covered. Can you define for me what out-of-network coinsurance means?
So in the plan as you have it today, we do have a network called Healthcare Highways, which is a limited network by definition and by practice. So it is not intended to be every provider. What it does provide for is much better pricing, particularly at hospital level, than what Blue Cross or Aetna or United Healthcare is doing. So it was designed that way on purpose. If a person goes out of that network, we're perfectly fine with that. Then that claim is paid as on a reference-based pricing model, meaning we're paying a percentage above what they would be paid under Medicare. It depends on the type of provider as to what that number is. So from a member standpoint, their deductible coinsurance is the same in or out of network. It just matters how that claim gets paid, if that makes sense.
Kind of. So the statement of all providers are covered is somewhat misleading there, because an individual could go to have a procedure, get to the hospital, and then the hospital says, we're not taking that because we don't want to deal with Kempton at all. So then we have to get into the whole issue of calls have to be made, and it becomes a very stressful event for our employees there. And I'm sure you know what I'm referencing.
Of course.
So I believe that's a misleading statement that everybody is, or all providers are covered. We also know that a provider that several of our employees were using for certain services finally said, I'm not taking it anymore. And they're because of the back and forth and having to agree with it. On the yellow TRS active slide, not the gap side, but it could apply to this one because I think it's the same thing. It says enhanced benefits not covered under TRS, Blue Cross Blue Shield, and it has there in parentheses, Val Verde Regional Medical Center, other things like that, imaging, stuff like that. So is that saying that Blue Cross Blue Shield will not cover anything at Val Verde Regional if an employee has to go there for a CT, MRI, stress test, stuff like that?
No, that is not what I'm intending to say. Those providers, I'm certain are covered by Blue Cross, but under your current arrangement, those are covered at 100% with no cost share by the patient. I'm sure Blue Cross has those providers, but it would be subject to their $2,500 deductible and then 30% and all of that. So no, it's not meant to say that those services are not covered by the TRS plans. It's simply saying currently those are part of our enhanced benefit program, and those are covered at 100% for your members.
Another statement that was made there, and you can help clarify if I'm wrong, was something about there was no out-of-pocket with Kempton at some of the, when you go to some of these, to go have procedures done and different things like that. So if someone went to a hospital and had a major procedure, this is alluding that there is no out-of-pocket cost before they are wheeled into the OR?
No, what I'm saying is that things that are within that yellow band, we can source those so that the plan pays 100%. So clearly, anything locally at Val Verde Regional, that's the deal. It's covered at 100%. But we're covering surgeries when they engage us to work through the bundled procedure process, then those are paid at 100%, and there's no out-of-pocket. We've got, I don't know.
At
Tens of-
Val Verde Regional Medical.
No, no. We've had many members who have had procedures in San Antonio. We have many member procedures. We have a great facility in Austin. We've had one member go to Oklahoma City. No, not just here, but other places as well.
Okay. The Okay. I'll yield for now, sir.
Okay. Anyone else? Mr. Caldwell, I sit on the TASB board, Texas Association of School Boards, and there's 45, 46 individuals from across the state. Most of them are opting out of TRS. Once you opt out, you have to stay out 5 years.
Correct.
I'm trying to think of my employees, and every time we transition to a different system, it's a hardship on them. But I'm trying to figure out with this $2.5 million, it's quite a big amount.
Understood.
I've been telling our teachers that sooner or later, it's hard to pay 100% of their premium, that at some point we'll have to collect some amount from them. I think every time, for most of us that served in the field of education, we'd get a 2 or 3% raise, and that's the amount of the insurance costs. It went, for insurance premiums, and that's most of my career that I saw. But right now, it seems to be that the employees are happy with the plan that they have. I have not heard any complaints here lately. Every time we transition, we hear those complaints, but until the kinks are worked out. And so I'm thinking, with everything else that goes up with the cost of living for everything from supplies, consumables for the classroom, to furniture, to HVAC, to parts and things, everything has gone up at a pretty much a rate of 8%, including food. So we're trying to figure out how we can do this to, again, not transition, but to be able to work something out where we can provide insurance for our teachers. Now, it might be that we'll arrive at a conclusion where part of the premium will have to be paid by the employee. At some point, we're going to have to make that tough decision, which every time I go to convocation, I tell my teachers that sooner or later, it will happen.
Yes, sir.
But yet I'm trying to make the transition where, everything's going good. And this is my opinion, that I would not want to switch and start all over again with a different system, but try to work things out where we can find a happy medium to have everyone insured, because that's the most important thing. Some of the questions that come up is there an alternative to Ozempic and Wyobi, or what the other one? Is there something else coming that is
I'm not aware of
comparable?
anything to replace those, and it'll be a long time before there's generics for those out there. So, Yeah, I don't see a lot of hope on the horizon for that in the short term. Those are gonna be continued to be prescribed because they are extremely effective, apparently, in controlling diabetic.
So we are seeing providers that are prescribing, let's say, Ozempic,
Oh, for sure.
quite,
Yes, absolutely.
yeah, I know the costs are astronomical.
Yeah, it's about $1,000 a month for
Mhm.
any of those. So, you know, right off the bat, you're talking about an expense of $12,000 to $15,000 a year for that individual, just for that. And so it is expensive. On the other side, if it prevents that heart attack or stroke or amputation, then, you know, money well spent. But I'm not decrying the efficacy of these drugs. It's just the reality of what they cost, and so we have to plan for it.
Okay, in your experience, do you know of any other districts that are providing 100% of the employees' insurance?
Yeah, there's some. Yeah, some that we work with that do, for sure.
Would you say it's the majority?
I wouldn't say the majority. Most have some contribution by the employees
Mhm.
at some level. You know, it varies. But
And my other question, so let's say that they're prescribing Ozempic. How many years does it take for it to be a generic?
oh gosh, I don't know. It's well over 5. It's
5 years?
I think it's maybe 10. I don't know the exact answer to that
Okay.
question, but
I
it's quite
just-
a number of years because the theory is they have to recoup their investment in the research and development before it goes generic. But
Okay. I just wondered.
yeah, you know what we are seeing is, and not people on your plans necessarily, but people that want it for weight loss alone, which we're not covering it for that. We're only covering it with a diagnosis for diabetes, but people do want it just for weight loss, and they can't afford the $1,000, so they're going out, and there are compounding pharmacies who are essentially making it and selling it for $200 to $300 a month. You know, I can't comment on that other than the physicians I've talked to are very nervous about that and the quality and the effect. So, but people are doing it all over the place, and if you search for it, you'll find that out there. That is not, it's only allowed by the FDA at this point because there's a shortage of these drugs. People are having a hard time even finding it, even if they have a diagnosis and a prescription for it. So the FDA is allowing those compounding pharmacies at this point. They will not allow that, I don't think, if supply catches up to demand. So,
So right now, with a 6% increase, you feel comfortable with that?
I do, because I just don't see your costs increasing dramatically other than those two items that we discussed, and I think that the 6% will account for that.
Okay. Mr. Olindo?
Mr. Coldaway, thank you for being here tonight. I just wanted to go back, when we were talking about the district contribution options, and I just want to get a little bit more clarification. You were talking about if we were to go to TRS Active Care, it's a $6.1 million from the 10.4. From a budget standpoint, it makes sense. But from a healthcare standpoint, you're kind of like, it's not really, and I'm not saying these were exact words, but it's not really the greatest idea. Clarify a little bit more why we're saying that, just to get an idea, because, and then I have a follow-up question for that, but is it because what the Blue Cross Blue Shield is offering is not comparative to what we have now, or?
It's because of a couple of things. One, there's no question the employees will spend far more. There's two costs to healthcare, right? There's the premium side, and then there's what do I actually spend when I go to use the plan. So there's no question that their out-of-pocket spend will be dramatically higher under the Blue Cross plans because almost everything's going to hit that deductible, right? So that's one component of it. The effect of a lot of out-of-pocket cost is people delay care, they don't get the care that they need. And, you know, I know we've talked about it many times, but the diabetic program we have in place with Dr. Artie is already achieving great results for your members. That would go away. So they would be back to trying to get into endocrinologist in San Antonio and having maybe a 10 or 15-minute visit every 6 to 9 months, as opposed to a very targeted program where they have access and it doesn't cost them anything to get it. So those are the kind of things. Generic drugs under your plan are covered at 100%. Well, they won't be under those plans. And yes, it's only $15 or so, but hey, $15 and people start putting off getting care, things like that.
Okay. Now, looking at this, regardless if it was the 6.1 million or 10.4, does it make a difference in the decision of the employee contribution, if the employees had to contribute?
We're gonna go over that here in a little bit, but,
Okay.
but it absolutely makes a huge difference
Okay.
in what we can afford and what the employees are gonna have to contribute.
And the reason I'm asking is it makes a big difference as well. I think looking at it is the cost saving is understood, but does the quality of care go down? Now, I'm not saying that what we have now is perfect, because like Mr. Olford alluded to it, and hearing some of those stories, you do have providers that turn away. I've had a phone call that says, hey, I need this type of procedure, but they're telling me I have to go to Oklahoma to go get it done, or I need to go to Austin. The cost that comes with them is also, you know, hurtful at times. So, not saying it's perfect. I'm not also saying that it's bad either, but
Right.
what is the effort that you've seen that Kempton, are they doing a continuing effort to still bring providers or put more providers into the network here locally, or even going to Uvalde or anything like that? And I don't know. That's why I'm
Yeah,
asking.
no,
I
it's
mean,
a
is
good
there
question.
a continued effort from them, or is this basically, are we at a plateau?
Well,
of-
locally, I mean, we have no issues with local providers in Del Rio. I mean, I'm not aware of a single issue with the local providers. So in terms of what I think you're talking about, that program where we're covering everything at 100%, they call it KPP free, but
Yeah.
that's just kind of their branded name for it. That does continue to grow. It's not going to grow here. There's not enough demand here, but it is growing in San Antonio. So when we started this, about the only surgical options we had were in Austin, and we had great options in Austin for just about any kind of surgical procedure that you can do on an outpatient basis. Since that time, though, we've got a couple of surgery centers in San Antonio.
Okay.
We have a cardiac and pain management facility in San Antonio. So that does continue to grow in San Antonio, at least. It's not going to grow here. There's
Okay.
just not enough demand in Del Rio for that to happen. I think your providers are doing all they can do to manage their business.
No, definitely. It's just looking at it from an employee standpoint, where they
Yeah.
would have to go for the care. And I've heard some good stories, right, where, you know, whether even for, you know, other procedures, they've gone to Austin, been covered at 100% for the
Yeah.
most part, just getting over there. And some people that have also been helped with hotels, you know, at
Right.
night and so forth. So it's understood. It's just, I know that sometimes it can be an issue, you know, with the providers trying to figure out where. My question was just kind of clarification of, okay, you're saving money, but it may be a rough plan to go with as compared to paying more, and you still have a good plan, but also, I think it'd be, you know, also listening, you know, with employee benefits to try to get an outlook of what has been the consensus since this plan has started for the last 2 years, and what would the employees like to see as well. So that's just kind of where I was going with it. So I thank you for clarifying that for us, Mr. Coldaway. Thank you, sir.
I would clarify one thing, and it's just something you mentioned. Employees are never told what they have to do. For example, you have to go to Oklahoma City for this procedure. They're given that as an option. not as, if the option is, yes, you can go to Methodist in San Antonio and get this done, you have your deductible, you have your out-of-pocket, it'll cost you $5,000, or you can go do this and it'll cost you zero. So it's never a
Just a one-stop, they're giving
forced-
options.
My point is, it's never forced, they're given options of
Okay.
how they want to go.
Well, thank you for that.
Anyone else?
Follow-up.
Yes, Mr. Orfeld.
Going back to the Ozempic and Manjaro and stuff like that, as you said, we've seen an increase, or there has been an increase in those prescriptions for individuals to take it for diabetes, for heart-related issues as well. And there are studies that are beginning to emerge that show that Manjaro and some others are starting to show serious side effects, muscle loss, different things like that. And because it is being, to use a bad analogy, since it is being prescribed like candy right now, for the most part, for people who are diabetic or heart, does the healthcare industry or the insurance industry see it eventually become where there will be a tipping point that, much like doctors who are prescribing opioids like they were Skittles, where we're going to go down and we're eventually going to have a GLP-1 epidemic because of all the side effects.
I think you're 100% right, Mr. Overfelt. I think there's a lot of problems with these drugs, but I'm not a medical professional to
No.
make those judgments. But I 100% agree with you. I think there's going to be problems down the road as a result of these drugs. And there already are. There's already lawsuits over various issues, and I think it's problematic, but I don't have the medical training to
No.
say no. So.
Yeah, no, I understand that. Does Kimpton right now, the program that we carry, does it cover and provide for mental health care?
Yes. That's required by law for one thing, but yes, it does. Mental health is covered as any other.
So if one of our employees needed mental health, needed a therapist and stuff like that, it should be no problem to find a psychologist, therapist through
I would
Kimpton?
not say that, and that's true of any plan we have, whether a major insurance company or otherwise. There is shortages of those kind of providers, and it's difficult to get into those people under any circumstances.
But it's covered.
It's covered, but it's difficult to see them.
Okay. I know we all hear different things as far as it goes to the insurance there. Personally, in the days leading up to this meeting, I polled and talked with various employees about their experience with what we currently have versus, hey, if we went to something like this. And the reality is 75% of everybody that I talked to said they would rather go to something else, even if it meant paying something else there because of issues that have arisen. I have this Blue Cross Blue Shield program because I'm an employee of the state there, and everywhere I've gone, everything that I've needed, it hasn't been an issue for me being told no, we're not going to take it or anything like that. So I would, while you said nothing that can be done until 2025, there for TRS active, and we will be going through or be using the current option coming into this next or through this next school year. I would propose to the board and to administration the possibility of putting a survey into the field amongst our employees there to go in and try and gather some hard data on what they are feeling about the insurance, because there will be positive and there will be negatives. And I think that I do believe that survey should have an option in there of would you be interested in going to another insurance, even if it meant you were paying $66 a month, $12 a month, $100 a month, there to try and get a data point and data set so that once we start to get into 2025, there's something to go in and look at. But I do appreciate all the information, sir, there, and you coming down and giving us the report on where we stand and where we're going. Thank you, sir.
Thank you, Mr. Overfeld. Dr. Rios?
Thank you, Mr. Mesa. Wanted to point of clarification. We're currently working to get some information. There are some indications that we might be able to join TR Active Care in January and not wait until September, because if your plan year ends in December, they will do, or they have done in the past, a coverage program to carry over until the September plan. So I know that Ms. Garcia and Amy Childress are actively researching that piece. So hopefully we'll have more information in the days to come. The other point that I wanted to make is that if we wanted to provide full coverage to our employees, the only way that we can do it and move forward in the years to come is by going to a plan that is affordable, which is the TRS Active Care. It's $376 a month compared to $918 a month. That's a $600 difference per employee per month. I'm not comfortable with that, but as Ms. Childress does the rest of the budget presentation this evening, and as much as we'd like to keep the transitions for employees, it is extremely difficult to say that we're going to pay $918 a month. First, there is no more fund balance after this year. And the reason that we've been able to provide the coverage that we have is because we have depended heavily on fund balance and ESSER funding over the last 2 years. I've heard a whole lot of stories about how, my husband got this surgery, I got this surgery, et cetera, and it didn't cost us a penny. And they're thankful and they're appreciative. I've also heard some of the stories about I had to make this phone call and I had to wait for this to happen. I've heard those as well. But at the end of the day, each employee who has these events is paying a whole lot less or paying nothing at all. But our budget simply cannot afford it. So we're going to do a survey of the employees, but the survey is going to be more like this. If we stay with the current plan that we have, you would be expected to contribute X amount of dollars. So you're going to have to contribute one way or the other. Or if we go to TRS Active Care, you don't have to contribute unless you want these extra coverages. So that has to be part of the survey. But I can, based on the budget that we've studied intently for the last 12 months and leading up to this first budget workshop, I can assure the board members that it would be extremely difficult to continue to provide these type of services. My recommendation to the Board of Trustees about healthcare is that when we approve the budget, that we approve it at, we're not approving a health plan. We're improving the allocation of what we can afford. So my recommendation to the board is that when we approve the budget, we approve a contribution of $376 per month. And then we ask the employees, this is how much we can afford. $376 a month buys you 100% of your coverage through TRS Active Care. But if you'd like the current plan, this is what your contribution would have to be. And it's difficult, but if for years, the board has been telling employees, there's gonna come a time where you have to contribute. And I know that I've told the board the last 2 years, we can cover the current plan this year and next year, but we can't cover it after that. Well, we're there this year. This is the year. And there is no fund balance to keep saving it. That's just the reality. We don't have that fund balance anymore. We don't have the fund balance in the healthcare plan, and we don't have the fund balance in the general fund to continue to do this. So I want to be abundantly clear about the administration's recommendation. The administration's recommendation is going to be to allocate $376 per employee per month. And then if the survey says that they're okay with TRS active care and not pay anything, well, then that's what we go with. Or if the survey says we're okay with staying with healthcare, highways, except that I know I'm going to have to pay $400 a month out of pocket. I just don't think the employees are going to go for that. But in our calculations, the responsible thing for administration to do is recommend that we allocate $376 per month, and then we ask the employees, okay, what do you prefer, A or B? But all we can contribute is $376 per month. I think when Ms. Childers makes her next presentation, I think that you'll be able to more clearly see why I'm saying what I'm saying, and it's just a ugly reality. Yeah? But here's the other part: if we do $376 a month and the employees go with TRS Active Care, then our custodians, our cafeteria workers, the lowest paid people in the district, at least have an affordable plan because they don't have to pay anything out of pocket. But if we go with anything else, then we're asking our lowest paid employees, even if we do a tiered system, we're still asking them to pay something. And it might be okay for somebody who's a teacher or maybe a paraprofessional who's worked for 30 years and they're making $50,000 a year, they might be able to do it. But everybody else, even if you do it on a tiered system where the lowest paid are paying less, it's still going to be something out of pocket, and that's very difficult to ask them to do. And that's where we're at, and it's ugly, but that's where we're at.
I just want to interject something else. TASB provides consultant services when you're comparing insurance, and they'll do an analysis whether you're better going to TRS or you better staying away from TRS. And they provide that free service. So would you be able to do that?
Absolutely, as long as they consider our budget, and that's part of this.
Yes. No, they'll tell you whether, it's a better deal or not. Free of charge. Mrs. Webb.
Sir, you mentioned that with TRS, the employees would have to go with specific doctors as their primary doctor. That's from their list.
They would have to select one, yes.
Okay, and right now, a lot of our employees have their primary doctors, and they're already seeing specialty doctors. And now we're gonna have to look at finding a primary doctor from the provided list, and then we have to get approval from them to go see one of our specialists. And
Now, to interject there, I suspect that Dr. Cadena and the others are primary care physicians with Blue Cross. So I'm not suggesting they would have to change
right.
that primary care provider.
But a lot of the employees don't go to Dr. Cadena or some of the doctors here.
Yeah.
So that was one of the questions, because a lot of our employees do have specialists that they already see, like you mentioned, and they might need a knee surgery. I'm not gonna go to a primary doctor to get him to refer me to Dr. Galindo over here, and then he's not on the list. Well, you can't go see him. You have to go see this one or this one, but I want this one, So those are some of the things that our employees right now, with the insurance that we have been able to see and feel comfortable with those doctors. And I know that some of these people, if they had to pay for them to go and see some of these doctors, they would still stay with them. because they feel very comfortable with them. But I understand our budget as well. But at the same time, if I were an employee of the district, I don't want somebody to tell me, select one of these as your primary doctor, and then figure out whom they have as a specialty so you can go see them, because the one I might want to go see is not on their list.
Well,
So,
yes, they're gonna be able to refer to any Blue Cross contracted
Right.
physician, which is gonna be almost all of them. So getting that referral to your physician of your choice probably is not a big deal. It is just that step and that process of getting a referral and selecting that primary care doctor is the main issue.
and then they have to be aware of the fact that they do have to pay a deductible, whereas right now they might not. And
Correct.
I believe, ma'am, you had your hand up a few minutes ago when Mr. Galindo was speaking. I don't know if you needed to say something or.
I'm so sorry, Mr. Galindo, when we were talking about the travel from here to Austin, if you hear of anybody who's participating in a KPP-free procedure and they said, hey, I had to drive to Austin for this, they should be getting reimbursed for their mileage, as well as their hotels that they have to book. So I know you were mentioning the cost of having to drive to some of these locations in order to have these procedures done, but all of that, including the mileage, should be reimbursed to them.
Mr. Galindo?
And thank you for that clarification. And it is a difficult thing because, yes, I mean, and Mr. Oldfeld is right. Blue Cross Blue Shield is also here in town, you know, so that's taken at a lot of different places. And when you're saying it like that, we're looking at having to make the lowest paid people pay. That's something also really that we got to look at. But I'm trying to, Mr. Coldaway, there's 3 plans here. Which plan are y'all proposing?
They have. the
It would be
employees
up to
have the
us.
choice of any
Okay.
of those three.
But are the rates for the 376, which plan is this, Dr. Rios?
It's the first one.
So
The
what we're
PC,
proposing.
the active care primary?
What we're
Yes.
proposing, if you look at, and I'm sorry, these pages aren't numbered, but if you look at the slide that has TR's active care with a gap plan, the district would fund the 376, but you can choose the active care primary plus. You would just pay the difference between 376 and 442. Or you can pick the active care primary plus and the gap plan, and then pay the difference between 576 and 511. So you have options on what you want to do as an employee. You can pay for the premium plus, and you can add the gap plan to that. I'm saying that our recommendation is that we pay 376 for every employee.
Okay.
And then they choose if they make 0 contributions, or if they want to add value to their plan and pay a little bit more. But at least that way, even the lowest paid employee has their insurance 100% covered, minus a deductible, right? But that's in any plan.
Okay.
One
And-
thing I would add is the rates that you see here, that's the rates today. They'll come out with new rates in May, June for the TRS active care program. So they'll go up, no doubt, at some level. So I don't know how much, but I just wanted to clarify. These are the rates that are today, but they will go up for next year in May or June. We'll get those numbers.
So with that, Doctor, is there still is a chance to provide basically 100% healthcare plan? And then they pick their premiums that they would want or which plan they would want to go to?
Yes, sir.
Okay.
That would, our goal would be to provide it at 100% of the cost for the TRS active care primary.
Yes, sir.
Even if it goes up, whatever it goes up to, we just have to be careful to safeguard some of that fund balance
Okay.
for when those rates actually come up. And we do expect that they would go up.
Okay. And I think there's pros and cons to both, right? To this plan and to the other one. And just, you know, as stated before, what we were saying, if we could just get an idea of what the employees would want, because ultimately, yes, it affects everybody no matter what we do. And, you know, whether it's Kempton or Blue Cross Blue Shield, which route to go, but I think that would be extremely important to see what they're willing to do as well, because ultimately it's in our hands to vote for what they want, but, you know, how is this gonna affect them? And you know, like Mr. Overfeld said, there's gonna be some who say that they would pay to get different services or better services, or a different type of service, how it's gonna work. And I think that all would need to be taken into consideration so we can make the best educated decision for everybody, because this is gonna have a long-term effect, no matter how, what we do this year, so. You know, again, thank you for the information, and thank you for clarifying that, just so we can continue doing our homework and see what would be the best solution. Thank you.
Thank you. Question from Mrs. Webb.
With a lot of our staff or employees dealing with cancer, how does that affect with TRS, active care, paying for everything that they need versus Campton paying for what they need? Right now, I know a lot of our employees are going through different things, and Campton has been providing for them and paying and doing whatever it is that they need as far as with chemo, radiation, et cetera. What is the difference?
I have no doubt they would receive those same services through TRS Active Care. And if they're going through a cancer treatment, they're meeting their out-of-pocket of, I think yours is $5,000. The difference would be their out-of-pocket would be higher. It's at $7,500 under these plans, but they're going to get the care, no question, under TRS Active Care as well, and probably from the same providers. So I would not foresee an issue with that continuity of care for them. It would just cost them a little more from an out-of-pocket standpoint.
Thank you. Anyone else? Thank you for the update, sir.
Yes, sir. Thank you.
Safe travels. Next item we have is budget projections. Amy Childress. It's all good, right?
Good evening, President Mesa, Dr. Rios, and members of the board. This evening, I'd like to bring you our first look at our proposed 2024-2025 budget. I have some slides that I will provide some information, and then I do have a first look at our interactive workbook that will have some more detailed information for us to look at. Okay, so the first item we'd like to look at before we get to the 24-25 proposed budget is a look at what we're looking at. Our estimated fund balance will be at the end of our 2023-24 fiscal year. So we have our audited fund balance at the beginning of this fiscal year is $41,405,885. We adopted a budget deficiency of $6,873,760, and we committed funds for projects in the amount of $12,730,176. So with that, we are estimating our fund balance to end with $21,801,949. However, we do know we have some adjustments that will be made to that fund balance. And some of those items are going to be, we had our ECF grant funding that provided the Chromebooks for our students. We had until December of 2023 to complete that project. Our fiscal year ended in June of 2023. So our auditors made an adjustment to where we deferred the revenue from that grant until we issued all of those Chromebooks. So we will be bringing back $1,120,215 back to our fund balance for this fiscal year. We also have committed projects that have either been completed and we have funds left over, or projects that we know we will not be completing and will not be asking the board to roll those to next fiscal year. Those projects are a health insurance contribution of $1 million. The Sinisa Hills Elementary project, we should be having about $950,000 left in that project. We had some asphalt work projects, and we have $2,249 from those. We had money set aside for some electrical work, which has been completed, and we have $8,000 left from that. We also had our E-rate projects, which we currently have about $10,000 going back to fund balance. And we had set money aside for student meals at Sinisa Hills, and we have $163,375 left from that to go back to the fund balance. In addition, we have about $1,350,000 left in ESSER 3 funding that we will be using towards general fund expenditures for this year. So with that, with those adjustments being made, we are estimating that our 2023-2024 ending fund balance will be $28,905,789. With the 75 days cash on hand, that amount is $22,232,469, which will leave us with a little over $6.6 million left in our available fund balance over the cash on hand that will be required for the ending fiscal year of 23-24. Going forward, for our 2024-2025 projected budget, we are currently projecting a revenue of $101,324,254. This is still a work in process. We will receive our first taxable property values by the end of April. Our projected expenditures are expected to be $107,942,462. What makes up those expenditures are wages and benefits of $77,538,067. The district health contribution, which is $8,831,851. Funding for substitutes, extra duty, and tutorials, $1,376,200. Currently, no general pay increase. Our campus budgets make up $781,779. Department budgets, $7,103,929. Operating budgets of $4,666,310. State programs, $4,064,738. Student programs, $1,863,988. Our energy savings payment, that's our 2018 maintenance tax payment, $1,330,600. And we have $385,000 from the Operations and Technology Sustainability Plan. Due to those amounts, we are projecting a budget deficiency of $6,618,208 for 24-25. So with that deficiency, when we put that for our estimated fund balance for 2024-25, we begin with our estimated ending fund balance for 23-24 of $28,905,789. $905,789. The current projected 24-25 budget deficiency of $6,618,208 would bring us to an estimated ending fund balance for 24-25 of $22,287,581. The estimated 75 days cash on hand for 24-25 would be $22,179,958, which would leave us $107,623 left in our estimated fund balance over our 75 days cash on hand. At this time, I'd have a couple slides that are proposed budget increases or reductions that administration has looked at. The first items we have looked at are personnel reductions in the amount of $1,712,578. The options that you'll see on your interactive workbook that make up this amount are to remove the elementary campus librarians. That would bring us a reduction of $591,882. To remove the elementary campus art teachers, that would bring us a reduction of $541,430. And to have assistant principals at every other campus would bring us a reduction of $579,266 to the current deficit we're projecting. In addition, we have also are proposing travel reductions in the amount of $296,784. That is made up of employee travel in the amount of $92,663, and student travel in the amount of $204,121. For the student travel, that is mostly made up of overnight travel, tournament play, things like that. The next item we'll look at for possible budget increases or reductions is the health insurance plan. Tonight, on our interactive workbook, we have two options that we will be going over. The first option one, is if we stay with the self-funded plan only. As Mr. Cordaway mentioned earlier, this would require an increase in contributions needed of $2.5 million. The district for July 2024 through December 2024 would keep our current monthly district contribution of $640.01 for all employees. In January of 2025 through June of 2025, we would reduce the district contribution to $376 per employee. Employee contributions would increase due to the offset of the district contribution decrease. However, this would offer a general fund decrease of $1,475,059. As I mentioned in an earlier slide, the district currently pays about $8.8 million out of the general fund towards district health contributions. So this would reduce that amount by the $1,475,000. Option two for the health insurance would be to finish out the calendar year with the self-funded plan and then move to the TRS Active Care in January of 2025. So again, we would operate the self-funded plan for July through December of 2024, and then operate the TRS Active Care for January through June of 2025. The district monthly contribution would remain at $640.01 for July through December. We would then move to the district contribution of $376 per employee for January of 2025 through June. Employee contributions would increase slightly, or could increase based on the TRS Active Care plan that the employee chooses. And again, with this plan, our general fund amount that we contribute would decrease by $1,475,059.
Mr. Mesa,
Yes, Dr. Rios.
I wanted to clarify something. At 1.475, we only get to see that amount because we're on the hook with Kempton until December. The following year, we would see an additional 1.475 in savings. So the total would be closer to 3 million. That's how much less we would have to pay if we, by choosing option 1 or 2.
At this time, I don't have any further slides. I do have the interactive workbook if there are no, if we want to.
Okay,
Continue
before you
with
do that, Dr. Rios, once you go into TRS, am I correct to say that you're in it for 5 years?
I think that there is a stipulation, sir, of how long you're in it and how long you can get back in it when you get out. So you're absolutely, they're not gonna let you in just for 1 year.
Right.
Yeah.
It's 5 years, whether it's good or bad, whether employees like it or not. Okay.
All right, I'll continue with the interactive workbook. And you do have copies of this in your binders, so I know the slides can be. Okay. So the first tab in your workbook is going to be for the committed projects. These are projects that we do currently have in our committed fund balance, and that they will not be completed this year, so we would be asking you to possibly roll these over for the 24-25 school year. The first one is the Cody Wardlaw Gym renovation. This is the district's portion of the commitment that we made, $1,198,764. The second project is the Del Rio Freshman Life Skills Road / driveway. That amount would be $437,533. We have the Del Rio Middle School parking lot. That would be $1,105,000. The remodel to North Heights for Cardwell, we have $1,419,445. And then we have the retention pond / Old Garfield roadway, which is another MOU we have with the city, for $80,000. So those are committed fund projects. The next tab I have is for the personnel that I mentioned earlier. So we have listed the 3 options, the elementary, removing the elementary campus librarians, the elementary campus art teachers, and having only one assistant principal at every other campus. For the purposes of this interactive workbook, we have selected yes to the elementary campus librarians and the elementary campus art teachers. So that would bring us reductions in personnel of the $1,133,312. If we were to remove if we were to select all options, it would be a reduction of $1,712,578. But again, for the purposes of this workbook, we've selected the librarians and the art teachers. For the health insurance, so at the top, I currently have our current contributions and the premiums that are being paid by the employees. So as you can see, the monthly contribution by the district for all plans, employee only, employee children, employee spouse, and employee family, is $640.01. That is the district's monthly contribution. For July of 2023 through December of 2023, the employees paid, employee only paid $0. Those with the employee and children plan paid $252.80 a month. Those with the employee and spouse plan paid $494.85 a month. And those with the employee and family plan paid $752.15. We did have a slight increase in January. And so they currently, employees on the employee-only plan pay $0. Those with the employee and children pay $295 a month. Those with employee and spouse coverage pay $580 a month. And those on the employee and family plan pay $885. That is our current premiums. So going into the two options that we're looking at, the first option is the self-funded only, where the district would continue paying the $640.01 for all employees for July 2024 through December of 2024. The employee contributions would stay the same amount that they are currently paying. Employee only would pay $0. Employee and children would pay $295 a month. Employee and spouse would pay $580 a month. And employee and family would pay $885 a month for July through December of 2024. Starting in January for the self-funded, the district contribution would decrease to $376 a month for all employees. However, the employees, those on the employee-only plan, would pay $582 a month compared to the $0. Those on the employee and children would go from $295 a month to $877 a month. Those on the employee and spouse would go from $580 to $1,162 a month. And those on the employee and family would go from $885 to $1,467 a month. Option 2 would be the self-funded for July through December of 2024, and then the move to TRS Active Care in January of 2025. Again, for July through December of 2024, the district contribution would remain the $640.01 that it currently is. The employee contributions would remain the same that they currently are. However, in January, we would move to the TRS Active Care, and for this purposes, I'm using the primary plan. But the district would pay $376 as our contribution for employees. Those employees that are on the employee-only plan would continue to pay nothing. Those on the employee and children would go from $295 to $264 a month. Those on the employee and spouse would go from $580 a month to $640 a month. Those on the employee and family would go from $885 to $903 a month, starting in January of 2025. For the purposes of tonight's workbook, we currently have option 2 selected, which would be the self-funded for the remainder of this calendar year, and then the move to the TRS Active Care starting in January of 2025. The next items we have are the employee travel reductions. So we currently have selected no for all of these. For this workbook, we do not have these reductions chosen. However, it could reduce the budget $92,663 if we were to choose those. The next tab we have is student travel. And as I mentioned before, this is all overnight travel, so tournaments, things like that. Does not include any type of district meets or anything that's required. We did break it down between registration costs, transportation costs, lodging costs, and meals. Again, for this workbook, we did not select these reductions, but it could reduce the budget $204,121 if we do select it. The next two items I have were discussed by Mr. Chapa in his presentation on the sustainability budget. The only items we currently have for this interactive workbook are the HVAC repairs, district-wide for the $250,000. We did select that item. The other items are from the technology presentation. We do currently have selected the HVAC, I believe it's for the server rooms, that's $15,000. The used department service trucks for $60,000. And we, again, have projects that qualify for the E-rate funding, and we have to set aside a 20% contribution, and that would be about $60,000. So it totals $135,000. So based on the selections that I identified in the interactive workbook, again, we currently have a projected revenue of $101,324,254. We currently have wages and benefits at $77,538,067. The current district health insurance contribution would be $8,831,851. The substitute extra duty and tutorials would be $1,376,200. We currently have no general pay increase. The tab of the reductions in personnel and salaries would be $1,133,312. The reduction to the district health insurance contribution, which is currently the $8.8 million, would be $1,460,811. Our non-salary categories would be our campus budgets at $781,779. Our departmental budgets of $7,103,929. Our operating areas would be $4,666,310. Our state programs are $4,064,738. Student programs are $1,863,988. Again, we currently have no reductions for the employee travel or the student travel. Our maintenance tax payment is the $1,330,600. And our operations and technology plan, the sustainability plan projects equal $385,000. That would bring us to a total projected expenditures for 24-25 of $105,341,339, which would be a projected deficit of $4,017,085.
Dr. Rios?
Thank you, Ms. Childers, for that presentation. Point of emphasis, just, it leaves us a $4 million deficit. Ms. Childers shared earlier that we would have up to 6.5 million, somewhere near there, still in fund balance to cover this deficit. However, for the following year, we still have to reduce the deficit of $4 million. It doesn't go away, it just carries over to the following year. But our hope is that that $4 million deficit would be covered, one, again, by materializing on the $1.5 million of TRS Active Care. So now it's down to $2.5 million. We think that the state, with the funding tables, would take care of $1 million, hopefully this year. That leaves us 1.5, and then the legislature meets again for the following year, and we're confident that something will be passed for increased funding, and then we would be even by next year. And we have to be even because at that point we don't have any excess fund balance. Now this is just one view on it. We are clear, administration is clear that the budget belongs to the board. We're just recommending what we know will work in the long run. But at the end of the day, you're the ones that click those boxes, and then we recommend based on what you click, based on your selection, because we're aware that it is your budget, it is your money, these are your employees. We just administer it for y'all. But our recommendation is just based on what the district can soundly afford and what we think is in the best interest of the employees as far as health care, primarily because we do not believe, one, we're certain we can't cover the insurance the way it's covered right now. And two, we do not believe that the lowest paid employees can afford to pay that much in premiums. Do I like TRS care? Not compared to what we have right now, absolutely not. But I also know that we cannot afford it unless the state was to have a special session next week and they'd say, hey, here's all this money. And that's our presentation, and we'll consider all your requests and comments.
Thank you so much, Amy. I just personally want to say that there's always a lesson to be learned, and that's, we have to be looking at the future and see where tomorrow is going to end, in regard to monies. When we're proposing a raise, it's difficult because we want to give the highest raise we can, and then that raise stays for the following year. So we gave a 6%. It's already, water under the bridge. But as far as cutting staff, I totally go against cutting staff. We need to do what we need to do, but, again, when we voted on the salary last year, it's just wanted to make sure that we didn't cut any staff, because that's what happens when, I want to make sure that everybody understands. A lot of districts are in the same predicament that we're in, because we expected some money from the state. It didn't come through. I don't hear anything in the background as in regard to a special call session for deficit budgets that were adopted throughout Region 15 and throughout the state. Many districts did that, thinking that we will be getting some money. But I do want to reiterate again and say that I am not the board member that is going to cut salaries and forget the increase in pay, but to cut personnel. It's I just don't want to see that. Whether employees have to pay $100 or more, then that's what I would want, with the stipulation that if money comes from the state, it would be given for raises, earmarked already for an increase. In my 37 years of service, there were 2 years that we did not get a raise, and yet insurance went up. And the cost of living wasn't as bad as it is now, but prices are not going to drop. They're already predicting $4 gallon gasoline by the summer, and so all these things have to come into mind, and as we make our decisions. And I asked Dr. Rios, and I know for a fact that once you're out of TRS, they won't let you in for 5 years. Once you're in TRS, you're locked in for 5 years. I'm not 100% sure on that, but they don't want you for 1 year. That's common practice. Most districts are opting out of TRS. That I know for sure. But again, we have to make a decision, and it's the most difficult decision. It is an election year. I'm looking forward in a couple of years, and I'm thinking, we need to go for this bond, again, and do some work that is needed. But when we talk about cutting staff and no pay raises, it's not a good picture to paint for the future. But, again, as we work on our budget, we always have to think, that everybody would like to give a 6% increase, but, again, I asked the question, I don't want to cut staff. But we were, again, projecting some money from the state that would be coming in as new monies. It didn't, and this is where we're at now. I'll pass it on to anybody else.
Yes, sir.
Mr. Starkveld.
I won't be as nice when it comes to what happened in Austin. We're fully in this position because of the failures of 181 individuals in the state capitol building and a governor and a lieutenant governor. They're because of special interest. Their public education was held hostage. Public education funding was held hostage. And now school districts are having to deal with those repercussions. I would love to see a special session here after May. I don't think it's going to happen. I think come January of 25, we may see some changes, and if special interest gets what they want, public education might be thrown some money, but the problem will be special interests, what they want, that money is going to have to come from public education funding, and thus we will be in the same situation again. Because of the failures of Austin, it falls to elected boards like us to have to make these very difficult decisions, dealing with budget, dealing with travel, employees, insurance, things of all those nature there, because we did not get funded this year. And I would like people to know, whether here or watching or later, that it is not the 7 of us up here. We have been put in this position because of the elected officials in Austin, because of bickering, because of partisanship, because of special interest. That's why we are where we are now, and having to make these very difficult decisions, having deficit budgets. And like Mr. Mesa said, it's not just us, it's school districts across the state of Texas. The page dealing with employee reduction there for librarian and art. Plain and simple, I will not support any budget that includes that in there. I cannot justify moving librarians into another position. I cannot, in good conscience, have our art programs taken away. Because unfortunately, in budget cuts, it's always art and extracurricular that are the first to suffer. And there was a news article just the other day, our news program, about the LA Unified School District and their music program that was featured in a short film that won an Oscar. And they're called The Repair Shop. And it stressed the importance of arts and music for districts that are socially, economically depressed, like LA Unified School District, like San Felipe Del Rio CISD, and others. I hope the 7 of us are able to come to a consensus, but I will not sign off on anything that has a reduction in those two areas of our employees. Thank you, sir.
Thank you, Mr. Orfeld. Anyone else? Mr. Alino?
And talking about that, just so it's known, we did receive an article today from TASB that states the myths and the reality of what shortcomings the state has done. And so everybody knows, during the last legislative session, lawmakers budgeted $3.99 billion for public school, but the money was never allocated, largely because they did not want to approve a voucher program, and that's what held it up. On top of, I believe, what we heard at the grassroots meeting, another $500 million that's just floating around that doesn't want to be given out to public schools. And unfortunately, that does put us where we're at today. But, I know we've talked about other solutions, about maybe how we can try to, go over this deficit over a couple of years. And I would like to see those options as well, because the same thing, it would be tough to cut any type of personnel. And they're just as important in bringing the education and these extra art classes and library. They also provide education for our students. And to look at cutting that would be something that would be very detrimental to the kids, and not only to that, to our employees and our staff as well. And so, I know it's tough for Ms. Childress. She's always done a great job, in Dr. Rios, but that is also going to be my opinion as well, that we have to try to see what kind of options we can come up with. We're still early on, but yeah, that's going to be a tough one to even go with, which I can tell you I would not. But, understand, echoing Mr. Overfeld's sentiments and Mr. Messa's, we are put in this position to try to overcome the obstacle of being able to fund public education in our school district and in our great community, and taking care of our students and our staff and our community. And I'm hoping that all 7 of us, we are going to, come together, and we're going to get it right, hopefully. But, I would like to see some other options presented as we go through the budget workshop. So thank you for your time.
Anyone else? Dr. Rios?
Just a couple of things to consider. The other options to not reducing positions are using up 100% of the fund balance and then putting us in a situation for the following year of what happens if the state waffles on us again. But the options are in the interactive book. You click no to not reducing or converting the librarians to teaching positions. You click no on it, but that does have consequences for the following year. But the options are there. There is no other funding options other than clicking what's on the workbook, checking, I say clicking, but selecting from the workbook not to cut those positions. But again, those are our only funding options. It just creates a bigger problem for next year with no cushion, because then the fund balance is completely absorbed. And if the health care that we're on the hook for until December, if the worst-case scenario was to happen, we have to be prepared to fund extra money. I'm not saying it's going to, but he did mention some big-ticket items. And if all those were to happen, which we don't know because we're not the doctors and we don't even know who the employees are. And we have to allot for additional money. We have to have some fund balance available for that. Or be willing to go lower than 75-day fund balance that the state wants us to have. But I want to just be very transparent. The options are there in that workbook. I think we can provide them
The USB?
a USB so that they can turn that in. We do have options, and they are there for you, but it moves the problem to next year. I think that in the 11 years that we've been together, this is by far the hardest year because we have to select insurance benefits and we have to select other cuts, and it's difficult. So if nobody thanks you for your service, I'm going to thank you because it's a hard one.
I just want to say again, there are options, because again, when I'm looking at everything, and I told Ms. Gonzalez, I have gone through scenarios left and right. There are options, and, for me, thinking, okay, we have a first in financial rating. State didn't come through, so, perhaps we don't get that financial first rating next year, and we borrow from our fund balance. But I want to know how much it would take for each employee to contribute for insurance for the rest. Because, again, I'm serious, as far as cutting staff, I think of people that just bought a car, just bought a house, and just made a big expense, and all of a sudden, they don't have a job. I can't do that.
Well, Mr. President, just there would be a reduction in pay, but we're not going to leave anybody without a job. There's plenty of teaching positions. It just means they make $200 less a month, depending, and that's difficult in itself because people went and got a certain certification to be a librarian, or they've worked as an art teacher forever and a day. But we are not talking about leaving anybody without a paycheck. We're talking about taking the art teachers and making them elementary music teachers, or making them some type of teacher at some level. And we're talking about taking a librarian and making them a classroom teacher, or some type of coordinator in some other position. We're not talking about leaving anybody without zero income.
For the last 2 years, I fought for librarians. So there was a time where we were going to slash librarians. And yet, reading is the most important subject. So I do need to have other scenarios.
I think, I'm sorry, just
So, Lisa?
also looking at, we're looking at the insurance, and that was a big topic tonight. When we looked at the cost for keeping the same insurance, which we haven't made up our mind which one I want, but I was talking to Amy here. What scares me is we're talking about the people that make $15 an hour that are at the end of the pay scale, or on the lower end of the pay scale. They're going to pay $291 every 2 weeks. That's $291. That's $582 if we stay with where we're at. So that really also puts us in a bind of what we're going to do, even knowing that it is maybe, say it was a better healthcare plan, it's hard to justify having to make someone who, is trying to live through the inflation and the raising costs that we're going through and just general life, to have to come up with $580 more a month for healthcare. And so, looking at the math, that's a tough one to also try to overcome and look at it. And that's what I was looking at right now, is $291 every 2 weeks if we stay with the same option one.
Yeah, I just want to say that if we have, for example, the statement that if we do get some extra money from the state, it will be going towards a raise. to overcompensate, for that expense. As, Mr. Orfeld mentioned, the governor is in line to get his vouchers. He has, again, politic enough to get people elected, and so he needs 2 more people. And so we have to realize that as much as we hate that, it will happen. It'll take money away from public schools for charter schools. We don't see the benefit here. In other areas, they have Montessori schools and they have all these other schools in every new subdivision. And those are the financial backers for the campaign when Governor Abbott is up for re-election. Everybody follows the trail of money, that's where it goes. But again, with the stipulation that if we do get some additional monies, it would go for employee pay raises. I'm just thinking out loud.
And just
Sure,
one last thing from me. We have those 10 positions on the interactive workbook, and I'll play the devil's advocate. In the last couple of years, we've added a whole lot of directors and specialists and strategists and stuff like that. Why not consider a reduction there and putting them back in the classroom?
Mr. Overfelt, we'd be willing to put anybody back in the classroom, but the reality is that the only people that we added were positions that were converted to lower positions. So, for example, the people that work in curriculum, they get paid a teacher's pay raise. The directors that we added are grant funded. So, for example, 2 that I can think of are the ACE director, that's 100% grant funded, and the data fellow was also grant funded. But we can definitely give you all a list of current directors that we have. I'm not opposed to it. The reason that I felt comfortable, might be the wrong word, but the reason I felt comfortable putting APs on the list, I know we can't run campuses without APs. It's impossible with everything we have. But, I have directors that I can definitely put as half-time APs, but then they're not going to do their job as a federal programs director or bilingual director or special ed director, because I'd have to shift their duties to the campuses. So there are other options, but they're all really hard based on what we're doing. But we just haven't added directors from the general fund budget. It's only been the ones that we're required to hire when we get a grant.
I'm just going to think out loud again. When I think of construction, to me, it's just stop sign, stop. No construction, nothing. Perhaps maybe when there's 50-50 with the city, which, there are some projects here. But there are some options, that, I think of facilitators as long as they have a job, going to some other position like that. We save some money on buses. We got electric buses. We're not spending money on new buses. But all these areas that we're cutting, we are the ones that are going to take, all the complaints about travel and so forth. We've had that before. So I just want, again, board members to think very carefully, and we need to pull for our teachers and our employees. And yes, I consider what Mr. Galindo said, that it would be a big amount for paraprofessionals and hourly wage. But with the stipulation that if there's new money coming in from the state, it would go for, again, teacher pay raises for all these employees to overcompensate for additional expenses. Anyone else?
I was thinking of something and then you said something else and I forgot. Oh, I know what it was.
Mrs. Webb?
I had to think about it. It's like, when we're talking about reducing staff and having assistant principals, not at every campus. I've been at campuses as an administrator and shared assistant principals with other campuses, where they go 2 days to one campus, 3 days to another, and then they switch the following week. And that's very, very hard and very difficult for the administrators on the campuses, especially when you're doing testing and other things of that nature. And so that was one of the areas of concern. And then, of course, with art teachers, if you have them teach music, I've got an art degree. I've got a master's in art. Don't put me in music. I cannot teach music. Ricardo Rios will attest to that. Yeah. But anyway, that's the other thing I had, question, Amy, and I know we have no on here for committed funds, under committed funds. And I know I had sent Dr. Rios a text regarding committed funds to remodel North Heights to Cardwell. Aren't we done with Cardwell? Why do we have $1 million committed to that?
Administration did the basic remodel. I'm sorry, I say administration, but we did the basic remodel. For example, we did the parking lot, we changed the water fountains, we changed the toilets, bought the furniture. But the plan was to enclose the hallways there at North Heights, now Cardwell. And that was the other half that we were going to start on as soon as plans were ready. So yes, that money is there, and it was to enclose the hallways. The word is escaping me, but the covered canopied area there,
Yeah.
we were gonna enclose that so that everybody would be under one roof. Yeah, most of the kids right now are under one roof at Cardwell. But obviously, the plan was to grow Cardwell and to make it under one roof campus.
To make it better. But I will tell you, sir, that where they are right now, it's 100% better than being at the old Cardwell where they were flooded and had water up to their knees. And I can tell you, I still have pictures of that scenario. So that would be something to consider as well, if we can hold off on that when Mr. Missa mentioned construction. And then the Del Rio Middle School parking lot. What are we adding to the Del Rio Middle School parking lot?
The district did a MOU, a memorandum of understanding with the county. The whole area behind the football stadium, Commissioner Vasquez applied for a grant with the federal government to do a sports complex type area out there. And they are going to develop that land and build a parking space immediately behind the football stadium, which we will then use that to have a bus loop and student drop-off loop to alleviate the traffic and provide another egress route for emergencies. Our part of that is that we buy the material for the parking area, and the Commissioner Vasquez, through their grants and their loans, will contract that out. Do we need all $1.2 million? We don't know, but whatever, whether it's 800,000 in material or less, the money's, that's what it's for. And that's one of those, it's not a 50-50 deal, it's more like a 30-70 deal where we'll do a lot less of the expense. But that's what it is. The district gets a whole lot of benefit, and it's a safety issue because it provides us an egress route in addition to the one we have in the front. Plus, it also provides handicap access to the stadium, which we really don't have right now.
Okay, for the sake of time, I think, I have a lot of questions, but I'll continue with Dr. Rios, as far as federal money and new federal money and so forth. But we thank you for the update, Amy.
Thank you.
I know your department works hard every time we have a, budget workshop and everything. So I thank you for the updates with everyone, and we'll continue working on this.
Thank you.
Thank you. We'll adjourn the meeting. Is there a motion for adjournment? Amy Haynes, seconded by Linda Webb. All those in favor? We are adjourned. Thank you and good night, everyone.